Hey guys, hello, hey. I wanted to do a quick OB neonatal review. The lecture on this was 4 hours, so I just picked the top 10 slides to review, really just highlighting the really important things that you should get from the lecture when you're preparing for the exam. First things, preeclampsia and eclampsia. This is a life-threatening pre-delivery emergency, so this is very serious. Preeclampsia, our patients can have headache, high blood pressure, and they just don't wake up with this one day and have it. It's a very slow increase in their blood pressure. Facial swelling, face and hands can swell. We talked about that pitting edema when you push your finger in for a few seconds into their leg and you release it. There's a pit where your finger was. Weight gain, mostly from the extra fluid causing the swelling. Some visual disturbances like some floaters or lights in their eyes. And those are the symptoms of preeclampsia, which is a pregnancy-induced hypertension. When our patient has preeclampsia or pregnancy-induced hypertension and then they have a seizure, that is eclampsia. So they're preeclamptic until they have a seizure, then they have eclampsia. And the treatment is O2, high priority transport, emotional support, because they're going to be worried about their baby. And then if there is a seizure, we do our seizure protocol, which is protect from harm, provide some O2. All of our pregnant patients we're going to transport on the left side, so we're going to turn them to left lateral recumbent and support the airway when the seizure is over if needed. Bleeding, okay, so less than 20-week bleeding, we've got two things to think about. Spontaneous abortion, lay people know this is a miscarriage. So it's when the pregnancy is terminated. So there's bleeding. The bleeding can be severe, and it can be mild, or it can be similar to a menstrual cycle period bleeding, or it could be hypovolemic shock, like a lot of bleeding. So our treatment is to assess, treat for shock, which is lay supine, oxygen, cover with a blanket, and call ALS backup and emotional support. Ectopic pregnancy, now we've talked about this in shock. We talked about this in the human body lecture. We talked about this in abdominal emergencies. So we talk about it all the time because it's a high priority surgical emergency. It is strongly associated with hypovolemic shock. If you remember, the fetus gets implanted into the fallopian tube, and as it grows, it ruptures the fallopian tube. So there's a lot of bleeding in the abdomen. Signs and symptoms can be missed period because they're pregnant, lower abdominal pain, it could be on the left or the right, depending on where the ectopic pregnancy is. Hypovolemic shock, so we would treat for shock and transport, call ALS backup, and sometimes referred pain, so it could be pain to the shoulder from blood under the diaphragm. Placenta previa, this is our last trimester bleeding, so we have placenta previa and abruptio placenta. Placenta previa is where the placenta grows over the cervix and the baby cannot pass through the vaginal canal. This is painless vaginal bleeding, and the baby can't be delivered because the placenta is providing the oxygen and nutrients to the baby, and it's covering the birth canal. So every time there's contractions and the head pushes down, there's bleeding, but it's painless. Abruptio placenta is when the placenta, again, that's responsible to provide oxygen and nutrients to the baby, rips or tears away from the uterine wall, and that is painful bleeding. And abruptio placenta can be from trauma. That's a common reason for abruptio placenta. It can be from drugs like sympathomimetics that might give a sharp rise in the blood pressure, so meth or cocaine. And also it can be for no reason idiopathic. Supine hypotensive syndrome. So we've seen this diagram before. This is the pregnant woman, and she's laying flat on her back, and you can see the aorta and the inferior vena cava. The aorta is carrying the oxygenated blood, so it's red, and the vena cava is the deoxygenated blood, so it's blue, returning to the heart. And when she's laying flat, the baby, this is the vertebrae here, so the baby is laying right on those big blood vessels. When we tilt to the side, the blood vessels open and can return blood back to the heart and pump blood back to the lower extremities. So to prevent supine hypotensive syndrome, we keep mom in left lateral position. And if she's laying flat, she can have symptoms such as hypotension, dizziness, and lightheadedness. We always transport pregnant people left lateral. Okay, delivery. Again, the lecture was 4 hours long, and this is just a brief overview and some highlights of delivery, but your role as an EMT is really to support the mom. If there's an urge to push or move the bowels, that's when you know delivery is imminent. So obviously, if mom said, yeah, before I get on your stretcher and go, I just want to go real quick to the bathroom, we don't let them go unaccompanied, because they could be wanting to move their bowels and then they could deliver in the toilet. Once the head is delivered, the first thing we do is check for a nuchal cord, which is the umbilical cord around the neck. If we see that, we want to reduce it and slip it over the head. Usually there's some give in it because it's twisted and it's kind of has secretions on it, so it's kind of slimy. So usually it slips over easily. If it doesn't and you cannot reduce it, you have to put the umbilical clamps on at the neck and cut at the neck, and then try to get the baby delivered as soon as possible by encouraging strong pushing. If there is meconium in the amniotic fluid, we want to suction the nose and the mouth with a bulb syringe before the body is delivered. When the chest wall is in the vaginal canal and it's compressed, there's no oxygen. And so as soon as the baby emerges from the vaginal canal and the chest wall expands, it creates a negative pressure, which causes an inhalation of environmental air. That change in the oxygen from the environmental air will shut off the fetal circulation and turn on neonatal circulation through a bunch of maneuvers in the body. And when that happens, the baby will start breathing, and before the baby starts breathing, we want to get all that thick, tarry meconium out of the nose and the mouth so they don't inhale it into the lungs, because we don't want sticky, tarry things in the lungs. It will affect the breathing. And this is the bulb syringe, and we squeeze it first. We put it inside the nose or the mouth, and when we release our thumb, the secretions go into that bulb. Here's our inverted pyramid of newborn resuscitation. So the pink is an EMT basic role, and most importantly, it is what every baby needs. So every baby needs dry, warm position, suction, stimulate. Not very many need oxygen, even less need BVM and intubation, chest compression. So it's inverted because these are the things least likely to happen. Everybody needs the pink though, dry, warm position, suction, stimulate. So as we're drying the baby off with a towel or a blanket, we're positioning them, keeping their airway in a neutral alignment. We're suctioning the mouth and the nose with our bulb syringe. And stimulating, we're really in the process of drying is stimulating. When we rub the back, babies really hate that, so they scream. And we can flick the soles of the feet with our finger. And we want them to cry and give a real vigorous cry so that we can force the fluid out of the alveoli, because in utero, before they're born, the alveoli are filled with fluid, and the crying forces the fluid out. If we don't make the baby cry from our dry, warm suction stimulate, if they don't cry, they may start this grunting respiration where they kind of where they grunt with all of their respirations. And we can treat that by stimulating. So we can, again, rub the back or flick the soles of the feet and get them to cry, and really vigorous crying will push all that fluid out and they'll start breathing normal. Okay, so for newborn resuscitation, when we're down at the lower parts of that pyramid, the way we determine what our resuscitation is assessing the heart rate. We can assess the heart rate. The best answer is brachial, when we feel and palpate the brachial pulse. You can palpate the pulse at the umbilical stump even after you have cut the cord. You can still palpate a pulse for a few minutes. So that's a good place to palpate a pulse. And then you can also, as in this picture, you can listen, put your stethoscope over the apex of the heart. That's called an apical pulse, and you can count. And all of these should be 30 seconds multiplied by 2. So if our heart rate's greater than 100, we're good to go. Okay, we're just going to continue to assess, keep the baby warm, and transport. Over 100 is good. We're 60 to 100, we're going to do bag valve mask ventilations on room air, reassess in 90 seconds. After that 90-second cycle, it's either really going to go 2 ways. Rarely does it stay the same after 90 seconds. So we're either going to have a good heart rate and we're going to continue to assess and keep warm and transport, or we're going to have a low heart rate, in which case we would do BVM with oxygen and chest compressions. It's the 120 event cycle, 3 to 1, and we're going to use the hand encircling technique for chest compressions and the neonatal bag valve mask. Okay, some complications of delivery. We've got our postpartum hemorrhage. So we're going to want to do a fundal massage to contract the uterus. Remember, the uterus, when it's boggy, it's like filling a muscle that's not contracted. And when you do a fundal massage, it's at the fundus of the uterus. Postpartum, that's usually just below the navel, which is your umbilical cord or your belly button. When you do a massage, it firms it up, just like when now your muscle's flexed, and it can slow the postpartum bleeding. Uterine rupture, this can be from a vaginal delivery after C-section, and it is a sharp, intense pain and loss of station. So we talked about the stations. They're minus when they're above the pelvis, and then once that we're below the symphysis pubis, then it's a plus station. So if the baby's crowning, you're at about a +2, +3 station. And you can see the head. So you see pushing and you see the head kind of coming out and going back in with contractions. And suddenly you don't see it anymore because the baby's gone back up into the abdomen. Then that's the loss of station. And then prolapse cord can be from, the presentation is the cord. So if you look, you see the cord dangling from the vaginal canal. The position we want to transport in is knee chest position, which is the same for breech or footling breech deliveries. And we want to put a moist dressing on the cord, and we want to feel the cord that we see. And if we have a good pulse, we can continue to monitor. But if there's no pulse, we want to put our gloved hand into the vaginal canal and push the presenting part off of the cord so we can get perfusion again to the baby and transport immediately. Just reviewing a few vocabulary words from this lecture. Prima gravida is first-time pregnancy. Gestation is the time in which the fetus develops. Braxton Hicks contractions, these are the mild, like false labor contractions. It doesn't increase in severity or time. So it's just, they just happen, they can go away. And uterine inversion, this can result from pulling on the cord. So after the baby's delivered, the third stage of delivery is the placental delivery, and we just wait for the placenta to be delivered. And if anybody really pulls on the cord, they can invert or turn the uterus inside out and it can come out. And menopause is the end of a woman's menstrual cycle. Okay, that's all I have. This is a quick video reviewing and highlighting the 4-hour lecture we did. Hope this helps you in your studying. Thank you, guys.